Good evening, everyone, and thank you all for joining us for this haematology webinar presented by the Harley Street Clinic, LOC, and HCA UK at University College Hospital. I'm Poonam, Relationship Manager for HCA UK Hospitals, and I'd like to take this opportunity to run through a short introduction before I hand over to our first speaker. For those of you who aren't familiar, HCA Healthcare UK are a leading healthcare provider delivering outstanding care for over 25 years, and more than 98% of patients would recommend us to friends and family. We have world-class facilities all across London, as well as Manchester and Birmingham. Our network of hospitals and outpatient centres cover all across London, making it easier and convenient for your patients to access outstanding care. What I'd also like to highlight on this screen is HCA UK's long-standing partnership with University College Hospital, providing patient care since 2006 and specialising in haematology and oncology. Now, I'd briefly like to tell you about our cancer services here at HCA UK. Our end-to-end care pathways provide holistic, personalised care and wellbeing support from prevention and screening through to palliative and end-of-life care. So what sets us apart? We're the UK's only private healthcare provider with a global research institute. The Sarah Cannon Research Institute is the first unit outside of the NHS to offer anti-cancer drugs in clinical trials. It provides rapid access to investigational drug therapies to both private and NHS patients at no cost to the patient. We connect over 300 expert cancer consultants from our UK's top teaching hospitals who work together in specialist MDTs. Our clinical nurse specialists are an integral part to our MDTs and are central to the coordination of personalised care plans. All of our hospitals have a level 3 ITU, and we have the supporting teams and infrastructure to provide both routine and complex acute cancer care. We're the only private provider with a molecular diagnostic lab providing in-house genomic testing that drives kinder and more effective treatment options and personalised medicine. And lastly, we have a dedicated cancer hub with registered cancer nurse specialists providing expert navigation and support to referrers and patients. Our cancer hub can help with suspected cancer referrals, second opinions, or questions about clinical trials and connecting patients with specialist consultants across our healthcare system. That's my whistle-stop tour, but if you would like to know about any of our services at HCA UK hospitals, please do not hesitate to contact me through the chat function or via our events team. Now, before we make a start, you will notice that you're not able to unmute your microphones. So please could we ask that you type any of your questions into the chat function to be read aloud at the Q&A at the end of the presentations. And now for the moment you've all been waiting for, I'll let Dr. Rismani load his slides. But it's with great pleasure to introduce our first speaker for tonight. We've got Dr. Ali Rismani, consultant haematologist specializing in the diagnosis and management of blood cancers, as well as general haematology. Dr. Rismani's clinics are at HCA UK at UCH and the Wellington Hospital. But let me hand you over to start the first presentation. Thank you.
Thank you very much, Poonam. Now, I've got to share things, don't I? Let's see how this is going to go. The slide. Good. I hope everybody can see this.
Perfect.
Okay, fantastic. Okay, so thank you very much. It's a bit weird not be able to see everybody and for the people not to be able to kind of speak back to me, but I'm going to just present some common cases that basically this is we got advice and guidance within our NHS kind of our NHS network, and these are some of the most common questions we get. And so I've just put them in some slides. I'm just going to go through things and kind of discuss, kind of talk through the things that can come across every day from blood results you get or questions that patients may ask you. So now, okay, so I'm going to start with raised vitamin B12. I know this is a common finding. Speaking to their labs, it's about 15 to 20% of vitamin B12s done in the labs actually are raised. And obviously it's something abnormal flags on the blood results. Patients want to know why it is. And it's quite a difficult one to answer actually, but it's inevitably benign. There are two conditions that can cause a raised vitamin B12 that can be concerning. One is if a patient has got myeloproliferative disorders, but as a rule, if the full blood count is normal, we don't need to do any further investigations. And people with liver disease can have a raised vitamin B12. That doesn't mean we necessarily need to go looking for liver disease in a lot of detail, like doing hepatitis screen, etc., etc. However, if the patient has got no obvious evidence of liver disease, there's no reason to think this patient has got liver disease, there's nothing else needs to be done. So if someone's got a raised vitamin B12, they've got a normal blood count, normal liver function, and there's nothing else that kind of suggests they may have liver disease, there's nothing else that needs to be done. And there's definitely no need to repeat the vitamin B12, because then also just to bear in mind that vitamin B12 can take a long time. We've got big reserves of vitamin B12 in our body, and it can take many, many months to go down. And also a lot of food are fortified with vitamin B12. So it's not an unusual finding to find raised vitamin B12 in blood samples. And it is kind of to reassure the patient that we don't need to worry too much about it. Now, low vitamin B12, this is always a tricky one because it's not always straightforward, but we are seeing it more and more, and there are reasons for that. I mean, we know that gastric bypass surgery for various reasons are much more common. So it is very common in patients with patients who've had gastric bypass or they had the stomach taken out for any reason. And it is very important for these patients on vitamin B12 replacement. And it is a common finding in patients with gastrectomies. It's also common with patients who drink a lot of alcohol. And it is also important to realize that people with low vitamin B12, especially if it's very low, they can have mental health problems. This is something which is overlooked a lot, actually. We know about the anemias and the macrocytosis that we see. We know about the neurological things that we can see, optic atrophy, impaired gait. But actually, there is a mental health problem that goes with genuinely low vitamin B12 levels. That's depression, psychosis, etc. So it's really important to kind of bear those, if someone's got a low vitamin B12, to try to find out if they genuinely have got symptoms of low vitamin B12, to look at all of those. However, we do also know that these symptoms are quite common, so we need to put it all together. And also drugs such as colchicine, pregabalin, metformin is a drug obviously is used a lot. They can all reduce impaired vitamin B12 absorption. So it's quite important to think about those before especially when it comes to giving IM injections of vitamin B12, because most of the time when you start giving IM injections, it's very difficult to stop. If the patient has got no symptoms, so nothing we discussed, doesn't have anemia, doesn't have microcytosis, doesn't have any neurological or psychological symptoms, and their vitamin B12 is not dramatically low, it's very reasonable to repeat it because we do see that when you repeat it, sometimes it's just back in normal and it's just a transient thing, or it was a sampling error. So it is very reasonable to repeat it if the patient is otherwise well. Because we know total vitamin, and also something also to bear in mind, total vitamin B12, which is what's usually measured, is not the most accurate. Is not the most accurate way of measuring B12. However, the kind of active vitamin B12, the autotranscobalamin, is not widely available. So it's not something we very often use. And also, as one of the messages was saying, obviously diet is really, really, really important. It is important to not, because I think what tends to happen, someone's got low vitamin B12, we start injections. And once you start injections, then it's very, very difficult to stop it. And this patient might end up being on IM injections for the rest of their life. Autoantibodies, obviously, this is something that is done, but it is positive if they got the antibody to peritoneal cell intrinsic factor and they got the low vitamin B12, then we could say this patient has got autoimmune gastritis causing pernicious anemia if they got anemia and macrocytosis as well. However, it's very important to also realize that they are not everybody with pernicious anemia has got an antibody. So it is all of these need to be taken. We need to look at the whole picture, and I know it's not easy. Sometimes GPs call me with it, and I can't quite work out what's going on as well. And If the patient is symptomatic and there's no obvious cause, and as someone just put it on the thing, if they're on metformin and you can't stop the metformin for various reasons, then you are obliged to start IM injections, bearing in mind that once you start IM injection, it is very difficult to stop, because it is very difficult to see what happens if you stop the IM injections for a long period of time, unless they get very close monitoring. And also, especially with patients who are vegetarian, who've got poor diet, who've got, say, gastric bypass surgery, oral replacement should always be tried first, because many of these patients, after oral replacement, the vitamin B12 goes up. However, again, it is quite tricky. I find this is one of the more trickier ones that I have to, when I get contacted about, to deal with, and it's just trying to put it all together. Low MCV. So patients with low MCV, with or without anemia, doesn't necessarily need to have anemia. And we know that 99.9% of patients with low MCV have either got iron deficiency or thalassemia trait. That's in London, especially, obviously, the diverse ethnic, it's a cosmopolitan city, so we get a lot of patients with thalassemia trait. As a rule, this is not 100%, but as a rule, if the red blood count, if you look at the full blood count, if someone's got low MCV with, say, mild anemia or even normal anemia, if the red blood count is low or lower end of normal, is usually iron deficiency. And in thalassemia trait, the MCV is low, but the red blood count is higher end of normal. So if someone kind of fits the pictures, fits where, say they're from South Asia or Southeast Asia, or they fit as someone with high risk of alpha or beta thalassemia trait, they've got a low MCV and a higher normal red blood count or high red blood count, is very likely to got thalassemia trait. And obviously, in a lot of times, you end up doing an iron profile. And if an iron profile, again, I know these days, we used to always say that ferritin, I think ferritin was kind of the standard kind of blood test everybody used to do. But nowadays, most people in primary and secondary care do a full iron profile. If the ferritin is high or higher end of normal, and the patient doesn't have anemia, it's quite reassuring they don't have iron deficiency. As we all know, ferritin is a reactive protein. It can go up with fatty liver, with inflammation, infection. However, if there's any doubt, then we should do a full iron profile, which includes serum iron and transferring saturation. And in a primary care, I think transfusion saturation is probably the best way to assess iron status in a patient. So if ever in doubt, I would do that. I would do a full iron profile rather than just ferritin. And obviously, HB electrophoresis is very good at picking up, is pretty accurate picking up beta thalassemia trait. Alpha thalassemia trait is, you can't, with standard HB electrophoresis, you cannot pick up alpha thalassemia trait, but you can see that if the picture fits with a low MCV, high end of red blood count, the patient's ethnic background, if it all fits, then you can say this is likely to be alpha thalassemia trait. It's very rare to need to actually do genetic tests to look for alpha thalassemia trait. There are not many clinical indications, the main one being if there is thought about kind of pregnancy, and if the partner also has got possibility alpha thalassemia trait. With low iron, obviously, if someone got oral iron is always the best. We all know that it's the most natural way of trying to bringing up iron. IV iron should always be second choice, but in a lot of cases, the patients can't tolerate oral iron, or the iron deficiency is so severe that we end up giving IV iron. And it's these days it's a much shorter way with the newer iron medication we have. It can be given over a 15-minute period, but considering it can have reactions, you can get reactions to IV iron, including allergic reaction, exacerbation of your asthma. So all those things need to be considered before a patient is considered for IV iron. And if you got, on the other hand, if you got raised ferritin, obviously we consider reactive process fatty liver. But if the transferrin saturation is over 40%, So we always need to consider hemochromatosis as long as the patient is not on oral iron. If the patient is on an oral iron, transferrin gene saturation is over 40%, that is actually in the guidelines, then we should consider hemochromatosis. And then that should be, the patient should be consented for genetic mutation analysis for hemochromatosis. Next one, raised platelet count. So raised platelet count, by far the most common cause of raised platelet count, especially in a hospital setting, is inflammation or infection. Usually patients have bloods done because they had a chest infection, or in primary care, or chest infection or pneumonia. And you can see the raised platelet count. And that's by far the most common cause of raised platelet count. And also, it's important to bear in mind, it takes quite a while for the platelet count to normalize. It can take 6 to 8 weeks for the platelet count to go down. So there's no point repeating it too early. 2 weeks is very unlikely to have gone down. So if you think it's inflammatory or because of infection, and that inflammation hasn't resolved, give it a good 2 to 3 months before you repeat it to make sure it's come down. Iron deficiency can cause a raised platelet count in about 35 to 40% of people. Is usually a mild thrombocytosis. It's usually between 4 to 550. So it's usually a milder form of thrombocytosis you can get. So it's always worthwhile checking the iron profile. However, if a patient has got persistent thrombocytosis and or is above 800, then you kind of need to exclude a bone marrow pathology. In most cases, if it's just isolated from thrombocytosis, you need to exclude essential thrombocythemia, and that's when the referral is made to us, and we look for JAK2 CALR MPM mutations, which are the most common mutations we see in thrombocytosis. But these days we do a whole panel of mutations to look for any abnormalities in the bone marrow, because these patients, it's important for these patients to be referred if they got persistent thrombocytosis, because they're all at high risk of arterial and venous thrombosis. They all need to be treated with aspirin, and if they fall in the high risk group, some sort of cytoreductive treatment to bring the platelet count down. Raised hemoglobin and hematocrit is most common cause in this country is chronic lung disease. You get relative hypoxia, positive feedback to the kidneys, more erythropoietin production, and you get a raised hemoglobin. It is important to also bear in mind that renal tumors, about 30-35% of renal tumors produce erythropoietin, and about 5 to 10% of liver tumors also produce erythropoietin. So if someone's got raised hemoglobin, we also need so if someone refers a patient to raised hemoglobin, I get smoking history, any history of lung disease, that can be COPD or smoking history, etc. I always do ultrasound abdomen to look for renal liver tumors. If they got a primary cause, you always look for the spleen anyway. People who live in altitude, you get, again, this relative hypoxia, you get a raised hemoglobin secondary to that. And also things like dehydration or diuretic use can cause what we call relative polycythemia, where because of dehydration, you get a raised hemoglobin. And again, primary polycythemia, usually JAK2 mutations, there are other mutations that can cause it. So if someone got a raised hemoglobin, we don't know an obvious cause, then obviously we need to look for a primary bone marrow issue, and that's when we send for the mutational test, like in essential thrombocythemia. A raised eosinophil count, I must say this is one of the ones that I really dislike because they're always really tricky, and there's so many things that can cause a raised eosinophil count. Hematological condition cause raised eosinophil counts are actually very rare. In this case, obviously, medical history is really important. In worldwide, it's usually parasitic infections, most common cause of raised eosinophils. In the West, is usually things like asthma, eczema, psoriasis that can cause raised eosinophil count. So getting a very good medical history is really important. And then, patients with low level, this is in the BSH guidelines, is in British Society of Hematology guidelines. Patients who've got eosinophil count of 0.5 to 1.5, they're otherwise completely well. It's not unreasonable not to do huge number of tests. It's very reasonable to repeat it. And if it's still low level, and they're completely well, it is reasonable to stop investigations at that point, as long as there's nothing else that you would worry about. However, if it's persistently high, or if it's going this upward trend, then I think then they need further investigations. And I think depending on the history, that can be infectious diseases, it could go to a hematologist, and it needs to be looked into further. And again, investigating race in a field can is always involves a lot of investigations, and to try to get to the, if you would want to get definitely to the bottom of it. Next, lymphocytosis. Obviously, especially in younger patients, I think if they got features of viral illness, otherwise well, definitely worthwhile repeating at least 6 to 8 weeks, minimum 6 to 8. Again, it's same as raised platelet count. You need to give it a good amount of time, 6 to 8 weeks. I would say even a bit longer, 2 to 3 months, to repeat it. If they're otherwise well, you're not worried about them. You just got this isolated lymphocytosis. It's very reasonable just to wait to 6 to 8 weeks. However, if it's persistent or in older patients, it is likely to be a mature B cell neoplasm. So most commonly CLL, that's the most common thing, or a low-grade lymphoma like follicular lymphoma, mantle cell lymphoma. So I think persistent lymphocytosis generally is likely to be a low-grade lymphoproliferative disorder, CLL or lymphoma. I'm going to talk a little bit about CLL because it's so common. And when it comes to hematological malignancies, is a mature B cell cancer, is the most common leukemia, is a little bit more common in men than in women. Lifetime risk is about 1 in 200. It's probably higher than that because a lot of patients are out there which never get diagnosed. Most people present with lymphocytosis. I come with it in a leukemic phase. There are a few number of patients that present with lymph node enlargement and not a bone marrow involvement. And obviously, it's mainly a disease of the older population, median age of 70. However, anybody at any age can get it. And again, this is something that is most likely you will come across, and is an incidental finding. Is 2/3 have got no symptoms. They present because they've had routine bloods done, shows a raised lymphocytosis, or they had a hernia operation, and the surgeon has seen abnormal lymph node, taken a biopsy. However, they can have B symptoms. It's like lymphoma. They can have B symptoms, fever, night sweats, weight loss. They can have recurring infections. And obviously, they can have symptoms from enlarging lymph nodes. So all of those need to be kind of considered. And again, most common is lymphocytosis, but they can present with enlarged lymph nodes, enlarged spleen, or liver. And obviously, it's a bone marrow problem. So if you've got lots of disease in the bone marrow, you can get signs of cytopenia. So because the bone marrow has been taken over by the abnormal cells, you get anemia or thrombocytopenia or neutropenia. And the patients with CLL also have got high risk of autoimmune stuff like hemolytic anemias or ITP. And they can also have a paraprotein, usually IgM paraprotein. I guess this is the question, when do you refer? A lot of people will say you should always refer if you think you got CLL, and that's very reasonable. I would say that and majority obviously is asymptomatic. If they got any symptoms or they got any abnormal bloods, they always should be referred. I'm going to go a little bit quicker because I think my time is running out. And what about if they've got a very mild lymphocytosis? The only reason I'm saying that because this has come up a few times. What if they're completely well, the rest of the blood count is normal, they've got a light lymphocytosis, a mild lymphocytosis, say 5 or 6? I think that's a judgment call, especially if you know your patient well. If you don't know it, I guess it's a bit more difficult, then you should kind of probably refer. And this is why, because obviously if you get a diagnosis, they've got a definite diagnosis, they can be looked after by a specialist, and all of those that goes with it. And however, I think if they got a low level lymphocytosis, nothing else, we've given them diagnosis, we end up giving them a diagnosis of cancer. There's a lot of anxiety that goes with that. It's got implications for insurance and pension. The only reason I'm saying that, one of our patients, very low level mortgage, couldn't get a mortgage because he was diagnosed with CLL. He was in his 50s. And so all these need to be considered. But on the other hand, if you don't refer, and then 3-4 years later it progresses, they might say, I can't believe my GP didn't refer me when my lymphocyte count was raised. So sometimes that's why if you know your patient really well, then it's something that it is not unreasonable not to refer, not to get that diagnosis. But I know it's really difficult. I think the temptation always would be to refer. Very quickly, CLL facts. Probably 50% will never need treatment because lots of people are undiagnosed. Progresses very slowly. The treatment for CLL is excellent. 5-year survival, 90%, is probably even higher than that. In younger patients, is even higher. And we don't use chemotherapy anymore. It's all targeted therapies, and people have to do really well and got limited side effects. They do have side effects, but limited, much less than chemotherapy with the treatments these days. And then my last slide is very quickly enlarged lymph nodes. If someone's got persistent enlarged lymph node and it's no obvious cause, then if it's axillary lymph node only, no other lymphadenopathy, they should go to the breast team. If they got painful lymphadenopathy is usually likely much more likely to be reactive, or infection should be reassessed in 4 weeks. If it's painless lymphadenopathy, then they should be referred to us, hematology, and isolated splenomegaly should also be referred to hematology. Hepatosplenomegaly tends to go by the GI team. All of these obviously depend on the other clinical history and other findings. But as a rule, the one thing that we always like, if they got isolated axillary lymph nodes, doesn't matter if they're women or men, they should go to the breast team because it's much easier for them to do the full assessment if it's just axillary lymph nodes and no other lymphadenopathy. Thank you very much. That's just over 20 minutes, sorry.
That was brilliant. Thank you so much for that excellent presentation. And thank you to our audience for your questions. We will, if they've not already been answered, we will address them at the Q&A at the end of the session. So I would just like to say we're now going to hand over to our second speaker for this evening. So we've got Dr. Elspeth Payne, consultant hematologist with clinical interests in MDS, bone marrow failure and AML, as well as general hematology. Dr. Payne's clinics are at HCA UK at UCH, and I'll hand you over now to start the presentation.
Thanks very much. Just see if I can get this up. Can everybody see the presentation all right?
Perfect, thank you.
Okay, thanks very much. So my name is Beth Payne. I'm a clinical academic. I'm associate professor at UCL, and I have a laboratory where I study causes of bone marrow failure and leukemias, and I do my hematology clinical practice at UCLH and HCA. I have a special interest and lead nationally for myelodysplastic syndromes and for another rarer condition that I'll mention a little bit today called clonal hematopoiesis. But today I'm just going to talk to you a bit about investigation of neutropenia. So neutrophils are the most abundant circulating granulocyte. They've got a very short half-life, so the neutrophil count can actually change relatively rapidly. The range at HCA UCLH is rather higher than average. It's 2 to 7.5. WHO guidelines suggest that a lower limit of normal of 1.8 times 10 to the 9 per litre. But in reality, we tend to not really be concerned about a neutrophil count until it falls below 1.5 times 10 to the 9 per litre. And a mild neutropenia would be considered 1 to 1.5 times 10 to the 9, a moderate of 0.5 to 1, and severe as less than 0.5. Very severe would be something like less than 0.2, which we'd refer to as agranulocytosis effectively. I think one of the most important things to say is that ethnicity really matters when it comes to talking about neutropenia, because these ranges are Caucasian ranges. So when is neutropenia not neutropenia? It's essentially for 60 to 70% of Black people, having a low neutrophil count is really normal for them. This has historically been referred to as benign ethnic neutropenia, but we prefer the term Duffy null associated neutrophil count now. And there's just a bit of interesting background to that. Duffy is an antigen that's expressed on the surface of red cells, and it's where the Vivax malarial parasite binds. And so people of sub-Saharan African descent have developed polymorphisms in this antigen, which means it's not expressed on the outside of the cell, so they're less risk for malaria. But that comes along with a neutrophil count commonly in the range of 1 to 1.5. And so anything above 1 is really acceptable in these patients, providing that's consistent for them. We would not consider that clinically relevant. We see similar findings in other ethnic groups, such as Arabs and Greeks, West Indian and Sephardic Jews. They're not all due to the Duffy null associated phenotype. There are some other genetic causes and some unexplained causes, but particularly in this subgroup of patients, this really is nothing to worry about. So why do we get neutropenia? Well, we have causes that are due to decreased production or a reduction in differentiation of cells. And most commonly, these are drugs and toxins. They can be bone marrow disorders, or they can be nutritional. And then there are immune and non-immune mediated methods of destruction. So again, drugs are one of the most common causes. And then we have autoimmune mediated neutropenias and splenomegaly, which contributes to the autoimmune mediated neutropenias. So causes of neutropenia, I think, are most simply divided up into isolated neutropenias and neutropenias that are associated with other blood count abnormalities. I think this is really important because an isolated neutropenia is actually much less concerning than a neutropenia that's associated with other blood count abnormalities. And they're also quite common in primary care. So it's important to sort of have a bit of a framework to think about when to be worried and what to be worried about. So probably the most common cause of an isolated neutropenia is infection, and that's usually viral infection, so not bacterial infection, viral infection. In Epstein-Barr virus, we usually see a high lymphocyte count with a low neutrophil count, and that's very self-limiting and no cause for concern. But also other viral infections, including things like HIV and hepatitis, very commonly lead to an isolated neutropenia. The second most common cause is drug-related causes, and I've got a slide on this, so I won't talk much more about it here. And then there are conditions where we see low neutrophil counts for no particular reasons, which are termed chronic idiopathic neutropenias. So these patients might be patients that you end up referring to us for a bit of advice and follow-up. But ultimately, if they have mild neutropenias that are chronic, that have been going for many years, not causing any problems with infections, and we cannot find any other underlying cause, we call those chronic idiopathic neutropenias. Now, interestingly, as time goes on and we do more genetic testing, for example, Ali was talking about testing for the genetics of patients who have high platelet counts, looking for primary hematological causes of that. We now start picking up things because those tests don't just come as isolated tests, they come as a panel of 50 to 100 gene tests. We've started picking up something called clonal cytopenia of uncertain significance. So that's when we see a mutation in a gene that we know might cause leukemia, but actually the patient is completely well apart from an isolated neutropenia. So that's kind of the future. That sort of routine finding and testing is just starting to come through. And I think perhaps when I'm talking to you in a year or two's time, that'll be something that we have more to say about. We do see inherited neutropenias still in the adult population, especially in the young adult population. And again, that's partly because these are patients who would have been labelled as chronic idiopathic neutropenias, but now that we do genetic testing and it's much more readily available and we know about more inherited neutropenia genetics, that we tend to pick these things up more frequently. There's also a condition called cyclical neutropenia, which tends to be cyclical, usually every 28 days. And patients can have quite severe infections with both of these sorts of conditions. Rheumatological conditions are a very common cause of isolated neutropenia, particularly lupus. Around 50% of patients who have lupus will have isolated neutropenia at some point. Usually tracks with disease severity. So usually when they're well, their neutrophil count is in the normal range, but when they're unwell and they're requiring changes in their medication, then they tend to become neutropenic at those times. We also see it in rheumatoid arthritis, but the range of medications that these patients are on, often it's difficult to ascertain whether it's disease or medication. And one caveat to all of that is that these rheumatological conditions do come associated with a small but nonetheless realistic increased risk of hematological cancers like AML and MDS. I guess the important thing to say is that isolated neutropenia in primary care, there's one study which looked at the proportion of patients who had an isolated neutropenia who then was discovered to have a hematological malignancy, and the number is actually really low. So it's about 7%. We also see autoimmune neutropenias. These can vary really rather broadly, so they can be mild neutropenias, or they can be extremely severe neutropenias. And the level of neutropenia doesn't necessarily predict how unwell that patient will be with neutropenia, whether they get infections or not. And that's likely to be because some of these immune neutropenias, the cells will be produced into the circulation and then subsequently removed by the spleen, and so there is actually production of neutrophils and ability to respond to infectious stimuli. But in some patients we do see really quite high levels of infection, so we're happy to review and assess these patients. So thinking a bit more about neutropenia with associated blood count abnormalities, medication again is kind of top of the list, and in particular cytotoxic medications. So you may be doing these tests on patients who you know to be on treatment for breast cancer or lymphoma or other cytotoxic agents for other sorts of immune-mediated conditions. We also see neutropenia, sometimes isolated, but more commonly with other blood count abnormalities in profound caloric deficiency, so anorexia nervosa. Now, in my experience with those patients, I've not seen severe infections, but they are described in the literature, and they do tend to respond to improvements in patient diet. We usually see nutritional neutropenia coming in when the BMI is somewhere around about 15 or lower. Nutritional deficiencies, more straightforwardly, Ali talked about B12 and folate deficiency. Copper is also sometimes a culprit of this, and in particular in patients who've had gastric bypass surgery or other sort of bowel operations, sometimes we see copper deficiency coming in. And then, of course, the hematological malignancies, so the acute myeloid leukemias, myelodysplastic syndromes, large granulocytic leukemia, hairy cell leukemia, and we talked a little bit already about clonal cytopenia of uncertain significance. And this is sometimes it comes along with a degree of risk of the development of AML and MDS. And so we're developing a service to try and capture these patients and follow them in clinic. Aplastic anemia, always in the list of causes of neutropenia, but the likelihood of any of you seeing a case of aplastic anemia in your career is low. It's an extremely rare disorder. We see probably between 10 and 20%, 10 and 20 patients per year in our NHS practice here, and this is the biggest haematology centre in the UK. So it's extremely rare disorder. So initial evaluation. The first thing that I think that it's worth thinking about if you've got a patient who's neutropenic is really looking at what it says on the report. So often you'll get a lab report that comes with the blood count, and sometimes it's not very easy to understand it because it'll be in lab speak. So the lab speak will be, essentially describing the size and shape of the cells. And sometimes something as helpful as neutropenia appears real or something not so helpful. But often these films where there is a new neutropenia will be passed to a doctor for review, and in those instances there will sometimes have written a suggestion for etiology. So for example, in the images here, the top picture, we've got a neutrophil that's got lots of extra segments in it. This is a hypersegmented neutrophil. There's also some very large red blood cells. So this is a macrocytic anemia with a hypersegmented neutrophil, and the patient's probably got B12 or folate deficiency. I'm going to go to the bottom right here. This is a lymphocyte, and it's got this kind of scalloping pattern around the edges of the red blood cells. So this is an activated lymphocyte, and that's typical of viral infections. So if we saw lots of these along with a neutropenia, you know, a useful comment from the doctor would be, note activated lymphocytes, consider viral infection, something like that. The other picture here, these are leukemic blasts, and if we see these on a blood film, usually you shouldn't have to be looking at the report. Somebody should pick up the phone and call you and or the patient to let the patient know, or arrange for the patient to be seen urgently in clinic. So I think just to reassure you that when really bad things happen, the laboratory is primed to make sure that we don't lose these patients in the ether, and that, you know, we have a fail-safe mechanism to make sure these patients get to us. So what's assuming that the patient isn't incredibly unwell when you get this result back and that we haven't told you to send them immediately to hospital, the first thing really to think about is reviewing the drug history. Now, drugs and toxins are really common causes of acquired neutropenias, but of course the list of potential drugs that can cause this is almost endless. Sometimes these can be really life-threatening, and you can get agranulocytosis, but more commonly mild, you know, lower level neutropenia, which is dose dependent, which really doesn't require too much in the way of intervention, is quite common. The most common drugs, of course, are cytotoxic drugs, so they are sort of obvious, and you know, your patient may be on treatment for breast cancer or whatever, but they're usually associated with other cytopenias. And reassuringly, the 11 most common drugs in the literature that cause neutropenia account for more than half of the reported cases. So I think from your perspective, these are the ones to think about. These are the ones to think, yeah, probably drugs, probably should stop these. And in fact, 3 drugs account for 42% of all cases of agranulocytosis, and they're methimazole, sulfasalazine, and cotrimoxazole. So there are some clear winners here that you can see. You can stop the drug, and providing the patient is well enough, monitor the patient and see if the neutrophil count recovers. So thinking about the more kind of worrisome aspect of this, you know, when is it an emergency? So, you know, why, I guess the first question is, why did the patient have the blood count? Are they unwell? And really prompt assessment is needed for those with neutrophil counts below 1. And if the patient is febrile, then the patient needs to be admitted to hospital as an emergency for IV antibiotic treatment. It's also reasonable that if there is no known, this is new and there is no known cause, and the neutrophil count is very low, and you're concerned about the patient, it's reasonable to send that patient to A&E. It's you know, it's also reasonable to wait till the next day if the patient's absolutely fine and ring the haematologist, but I wouldn't be upset if somebody sent in a patient with a neutrophil count of less than 0.5 just because they had a neutrophil count of less than 0.5. Now, of course, we should think about the things we know about. Does the patient have a hematological malignancy? Are they on cytotoxic treatment for another cancer or for a rheumatological condition? And are there other abnormalities in addition to the neutropenia? So even the subtle ones can be important. Things like, is the red cell distribution width increased? Is there a subtle increase in the monocyte count? Is the MCV normal? So one thing that, you know, sort of kind of hematologists speak about, you know, monocytes on automated blood counts, they're blast cells are often mistaken for monocytes by the automated analyzer. So I always have my ears pricked up a little bit if I've got a neutropenic patient and in front of me I've got a slightly elevated monocyte count. The analyzer will also sometimes pick up something just sort of not being right. So sometimes the count will come back as, you know, neutropenia with a kind of immature granulocyte flag. In other words, we don't think the cells are normal. But usually you should have a film report with that more formally has analysed what people think is going on. So if it's not an emergency, the patient's okay, the neutrophil count is mild or moderately reduced. Other things to consider are, you know, is there a prior history of infection or inflammatory process? Has this patient been, you know, having lots of issues with dental infections, chest infections? Have they been and had antibiotics multiple times over the last year or two? Is there something else that's speaking that you're concerned that this might be something that is a chronic and ongoing problematic neutropenia that needs to be further investigated? And do they have other things like lymphadenopathy, fever, night sweats, weight loss? Do they have any GI disorders, thinking about nutritional deficiencies? And do they have any existing known infections? And if you don't know, this would be something to make sure that has been tested. We've talked about medications. We've talked about diet, both in terms of nutritional deficiency and in terms of anorexia nervosa, which is, as I mentioned, a relatively common cause of neutropenia, particularly when the BMI is very low. Alcohol consumption can cause bone marrow failure, including neutropenia. And then, of course, the sort of more background, family history background. Is there prior history of neutropenia in the patient or in the family? Is there a history of bone marrow failure syndromes or other hematological conditions? So physical examination can be a little bit misleading sometimes in patients who have neutropenia, especially if the neutrophil count is very low, because you tend not to get the sort of classical signs of infection like redness or pus developing. What you do tend to find is that the patient can have quite poor oral hygiene, so that you can get sort of gum hypertrophy, oral ulceration or dental pain can be quite common findings. Also, you might think about other things that might suggest other causes, so joint swelling and pain for rheumatological disorders, and again, splenomegaly and lymphadenopathy. And I think Ali talked a bit about the neuropsychiatric aspects of other nutritional deficiencies and alcohol and HIV infection. So what additional tests are reasonable to do in primary care before you sort of think perhaps you need help, or first of all, B12 folate, copper levels for nutritional deficiency, and a viral screen, and replace the nutritional deficiency. In those severe nutritional deficiencies with anorexia, usually there is improvement with weight gain, but it can take quite a lot of time. And so we do quite commonly see these patients in the haematology clinic, really just to make sure there's nothing else going on. And for follow-up, with a new onset mild neutropenia who is well without any other clear cause, it's reasonable to repeat in 2 to 6 weeks and refer if no improvement. And for a moderate neutropenia and well without any other clear cause, I would repeat in 1 to 2 weeks and refer if no improvement. And for a severe, reasonable to just refer unless there's a clear, obvious cause. Talked a little bit about drug-induced neutropenia, but just to be more specific, ideally you stop any offending drugs that you think are causing the problem, but sometimes there will be critical medications that really you don't want to stop. So specifically things like psychotropic drugs, anti-seizure medication, and where there's no suitable alternative to sort of swap that out, and that can also involve discussing with patients other healthcare professionals. But often for these sorts of particularly anti-epileptic medications, they can often take years to get patients on the right anti-epileptic medications. You really don't want to stop it if you don't have to. And the neutropenia, if it's mild and if it's not progressive, it's reasonable to continue and just monitor. If you do stop, improvement does usually begin within about 2 to 3 weeks. In mild neutropenia, it's also less likely to represent an idiosyncratic drug reactions, and so therefore the drugs don't need to be stopped. So what I mean is, that what you're really concerned about is when the neutrophil count is very low and severe and likely to cause infections, and that's when you absolutely have to think about stopping the drugs. I'm also running behind time. So when to refer? Okay, immediate referral, within hours. Your haematology consultant at the hospital rings you up and says there are some blasts on the film. Please send the patient to A&E. They will call you. They might not say send the patient to A&E if the patient's well. We are a little bit more circumspect with seeing the patient as rapidly as we used to in our older historically. But we will see the patient and we will make sure the patient is seen very promptly. And similarly, if the neutrophil count is extremely low, then we would want a referral to the hospital. And I've not even put on the slide here, if the patient's febrile and neutropenic and unwell, it's straight to A&E with the instruction that they should tell the arriving team that they have neutropenia, and you should call ahead to make sure they're expected. Prompt referral, that means like within days, is really appropriate if you see other things that are described on the blood smear. Again, this is likely to be something that is communicated directly to you by hematologist in the lab. but you may find it on a blood film, and it may, it may have been slipped, and things like blast, dysplastic granulocytes, things that really are hallmarks of the possibility of a hematological cancer, plus or minus unexplained lymphadenopathy and splenomegaly. But Ali and Jam will talk a bit more about lymphadenopathy in his talk. And then the other thing is presence of progression of pancytopenia. So, we talked about when to repeat. Well, if it's getting worse, then we need to see the patient and make sure that nothing untoward is going on. So a referral that we might want to see at some point, but without any massive urgency, is, for example, if there are characteristic physical findings or family history that suggest a congenital neutropenic syndrome. These are usually diagnosed in childhood, but as I mentioned, with genetic testing, actually we start picking these things up in adulthood, and there's plenty of patients in my clinic that have congenital neutropenia that weren't diagnosed until they were in their 20s, 30s or 40s even. Worsening of neutropenia or persistence of neutrophils of less than 1 when the patient is well, but not due to these Duffy null-associated neutrophil counts or a rheumatological or disorder that's known, or hypersplenism. And then also importantly, inadequate response to nutritional deficiency that you can't really account for. So I think the one thing I would mention is the B12 deficiency. So I think virtually every patient I've ever seen with aplastic anemia had borderline B12 deficiency. And some of them took a while to come to medical attention for their aplastic anemia because they were rightly treated with B12. So just to sort of bear in mind, if it's not getting better, then you need to send a patient in. And one of the sort of, easy tricks is to look at the reticulocyte count, because the reticulocyte count will increase, telling you that your treatment is working, telling you that the red cell count's going up, and even before you perhaps see full resolution of the count. And then patterns of infection, so funny kind of patterns of infections or mouth ulceration, that's consistent with the sort of cyclical period of neutropenia. And we usually recommend that patients have regular blood counts every 2 weeks to try and identify a pattern of cyclical neutropenia, but that's something that we can always look at in the haematology clinic if needed. So I've done a little bit of a flow chart, but I'm going to just skip over that because I'm running out of time, and just mention what I think are the key points. The first thing is that isolated neutropenia is a common incidental finding in primary care, and it's most often drug-induced or caused by an acute viral infection. It's rare for a primary hematological malignancy to present with an isolated neutropenia, as other lineages are usually affected, even if it's only subtly. And the initial investigation of persistent isolated neutropenia should include a blood film, haematinics, and viral serology. And quite often we don't actually find a diagnosis in patients with an isolated neutropenia, and those patients are labelled with chronic idiopathic neutropenia, and providing they don't get infections and the neutrophil count is mild and it's not changing, we're happy for those patients to go on with their lives with their mild neutropenia. And the future, as I've said, holds some new genetic age-related causes of neutropenia and other cytopenias, with clonal cytopenia of uncertain significance and clonal hematopoiesis. And these have other health sequelae, which is what makes me think that you're going to start seeing these tests more frequently, because patients who have those conditions also have an increased risk of cardiovascular death and stroke. So I think these are things that we're going to start seeing in general practice in the next 5 years or so. And that's it. Thank you for your attention, and any questions, or maybe we'll take them at the end.
Thank you so much for that excellent presentation. Yes, we will do a Q&A at the end of the presentation. Thanks to our audience as well. You've sent through some great questions, so we'll be addressing those shortly. And now handing over to our final speaker for this evening, we've got Dr. Jamail Kothari, consultant hematologist and hemato-oncologist, specializing in the treatment of multiple myeloma, lymphomas, and the assessment and treatment of abnormal blood counts. Dr. Kothari's clinics are based at LOC, which is Leaders in Oncology Care at 95 Harley Street, and the Harley Street Clinic. I'll hand you over to start the presentation. Thank you.
Thank you very much, and good evening, everybody. So for the last talk today, I'm going to talk about paraproteins primarily, and then if we have a bit more time at the end, a little bit of extra information on lymphoma and lymphadenopathy. So I am an NHS consultant in Oxford, and I'm clinical lead for myeloma and associated disorders for Oxford University Hospitals and the Thames Valley Cancer Alliance. And as Poonam has said, my primary private practice location is with HCA in London. So to start talking about paraproteins, I'm going to start with a case study which illustrates a lot of the issues that I think are pertinent in both primary and secondary care. So if we consider a 78-year-old female, previously fit and well, who smokes 10 cigarettes a day and she probably drinks a bit too much. She has a long history of hypertension, but it's well controlled, and she comes to see you with a combination essentially of bony type symptoms. So she has some right shoulder pain limiting her mobility, and some non-specific chronic lower back pain, which she says is getting worse, and simple analgesia isn't doing what it's supposed to be doing. So the initial investigations done in primary care, you did some bloods and you did some plain films. So the full blood count shows a mild anemia, MTV a little bit high, B12 a little bit low, and the creatinine had been monitored for a few years and it was up a bit, but it didn't appear to be an acute issue. And some plain films showed some degenerative arthritis in the shoulder and some collapse of vertebrae in the lumbar spine. Now, to get bloods these days, you only have to tick a box, and so many people are now getting serum electrophoresis absolutely appropriately checked, and the result came back as an IgG kappa paraprotein detected of 12 grams per litre. So the question is well, what does that mean in the context of this history, and what should the next steps be? So hopefully the next few slides will help illustrate some of the key points that one needs to think about. But before we get into it, I think it is important to clearly define what we mean by a paraprotein and also explain what serum-free light chains are and a Bence-Jones protein is. So a paraprotein is a monoclonal immunoglobulin produced by a clonal plasma cell or a similar type of cell, a lymphoplasmacytoid cell. So our plasma cells are antibody factories, and in normal health, we all produce a variety of different types of antibodies that protect us from the variety of different pathogens that we have to face in day-to-day life. Because these are such active cells, if they get switched into an abnormal position, they produce the same paraprotein, they produce the same antibody over and over again, and you can measure that as a paraprotein. Now, a paraprotein is made up of heavy chains and light chains, and you can measure the light chains in the serum, and that's serum-free light chains, and your light chains are either kappa or lambda. So in health, we produce both kappa and lambda, and there will be a ratio of kappa to lambda, and over the last few years, it's been much easier for us to measure light chains in the urine, but historically, you could only measure light chains in the urine, and that's what a Bence-Jones protein is. So a Bence-Jones protein is a monoclonal light chain which is excreted in the urine, as not all of them are resorbed by the kidney as they pass through. So we're doing Bence-Jones proteins less and less these days because one can more easily measure light chains in the serum. But this leads to a lot of confusion, and I think one of the main areas of confusion is the scale of abnormality. So a paraprotein can be just detectable, and you can measure small paraproteins of 1 or 2 grams per litre, and that scale can go up to 50, 60, 70. Like a really big paraprotein of any sort is 70 plus grams. Whereas light chains are much smaller, and we have many more of them, and the scale is much bigger. So serum-free light chains in an abnormal patient can be anywhere from 100, 500, 5,000. So the scale is much bigger. And the ratio is very important, because in the absence of a clonal plasma cell disorder, you can have raised kappa and lambda light chains for a variety of reasons. For example, in renal failure, both of them go up. but the ratio should remain normal. And as we are increasingly understanding light chain excretion and the differences that are seen in different conditions with different ages, there is a continual iteration of what a normal light chain ratio is, and it is different in different age groups as well. So paraproteins are common, and the term MGUS essentially refers to a pre-malignant clonal plasma cell disorder where you have a monoclonal protein. So you have a paraprotein, and you can also have an excess of light chains, or you can have light chains only, or a mixture. And the key thing about MGUS is that it's not a malignant disorder. You have less than 10% of the abnormal cells that are producing the paraprotein in the bone marrow, and there's no evidence of active hematological cancer, which most typically is multiple myeloma. So if I took 100-year-olds, I'd probably find MGUS in 10 to 15% of the population, and at 50, you'll probably find it in 3 to 5% of the population. It was first noted probably in the 60s how these patients progressed, and it's been understood over the last few decades that there is a well understood progression of MGUS to malignant plasma cell disorders or similar disorders, and we'll talk about how quickly people progress in a couple of slides' time. So in general, you have an IgM MGUS, you have non-IgM, or you have light chain, and it is important because we're detecting increasing numbers of paraproteins. A lot of these patients are monitored in primary care, and there is a clear and persistent and well understood risk of progression to an active malignancy. What's also interesting and becoming much better characterized is that there is an association of MGUS with a number of other disorders, osteoporosis, for example, being one of them. And over the last few years, another term has come to light, which is MGCS, which is monoclonal gammopathy of clinical significance. So it's become apparent that there are a whole bunch of autoimmune disorders, for example, skin-related issues or neuropathies, where the disorder is driven by an MGUS type clone. And the best way of actually treating this type of condition is to actually treat the MGUS clone with a hematological chemotherapy, a myeloma type approach. So more patients are actually being treated for what initially looks like MGUS, but actually it's clear that the clone is driving a non-cancerous condition. And certainly as myeloma doctors, we're getting increasingly involved with those areas and working very closely with colleagues in neurology, dermatology, and other specialities. So this is just a summary of the different types of MGUS. I think the key thing really to take away from this table is to understand the risk of progression. As a general rule, the risk of progression of MGUS to active malignancy is approximately 1% per year for non-light chain MGUS, which means that there are groups of patients where they're never going to develop active malignancy in their lifetime, and there isn't really a risk for monitoring either. Light chain MGUS has a much slower risk of progression to active malignancy. So the question is, well, when should one refer? I think it's important to understand that if you're not sure and there's any level of diagnostic uncertainty, then we should see the patient. Classically, MGUS IgA and IgG MGUS will progress to multiple myeloma, and the typical organs that are damaged by active myeloma are the bones, with lytic bone disease. You get high calcium associated with that, and there can be unexplained anemia as well, and also renal impairment. So if there's any uncertainty that there could be some crab-like criteria, then absolutely the patient should be urgently referred. I think renal impairment is one that can become permanent if patients aren't seen rapidly and treatment initiated quickly. IgM paraproteins are more associated with low-grade lymphomas. Because IgMs are big, they're pentamers, and if there is a large IgM paraprotein, patients actually can develop hyperviscosity. They've got a lot of sticky protein in their blood, and they can present with features of this, which can be non-specific, such as confusion, but you can get retinal problems, headaches, nosebleeds. And again, I think if there's any uncertainty about these sorts of symptoms, then we should see the patient. So a small group of patients with MGUS will progress to myeloma, but of course myeloma can present with end organ damage, and though all patients with myeloma will have been through an MGUS phase, unfortunately plenty of patients will progress without us knowing that they were going to actually get to us. And day to day, I think increasing numbers of you in primary care will have more patients on your books with myeloma, because we're doing much better at treating them and keeping these patients alive. The difficulty, of course, is that the presentation can be extremely vague. Lots of non-specific symptoms, and of course, presenting with back pain. The majority of your patients who present with back pain are clearly not going to have myeloma, and the only way to ensure that this sort of diagnosis isn't missed is to think about it and actually tick that serum electrophoresis box, because clearly if a paraprotein gets associated with any of these symptoms and abnormal bloods, then it immediately goes to the top of a potential differential, and we get involved more quickly. So the effects on the major body systems, on the bone marrow, you can get a combination of issues, including anemia, immunosuppression, which leads to infection, which can be very significant. And we mentioned hyperviscosity, and because of the nature of certain types of aspects of myeloma, including presenting with hypercalcemia or high light chains, patients can present with renal failure, and these are the kinds of patients that we need to know about quickly and treat quickly. Lytic bone disease are the classic lesion that one's taught about, and these are a very typical presenting feature of the bone disease. And there can be a bunch of other associated bone disorders as well, including osteopenia and what look like osteoporotic fractures, but are actually fractures driven by a large volume of disease in the bone marrow. This is it's a slightly old study now, but highlights the presenting symptoms of myeloma and other hematological disorders, and I think really just highlights the what can be quite vague symptoms, but pain is a very typical presenting feature. So fatigue and pain are the most common side effects, and if you go through in a week how many patients that you will see, I'm sure fatigue and pain feature very highly. So it's not surprising that unfortunately diagnosis is sometimes a little bit delayed. Now, if we go back to our patient, this is a patient with chronic renal impairment, but some bone symptoms, a little bit of anemia. So when you put all these pieces together, you could very much make a story that, well, this is potentially typical for symptomatic multiple myeloma. And it's very difficult to tease out that history without a referral to secondary care, because we do need to use more advanced imaging techniques to really understand whether there was any background lytic disease. And actually it was confirmed that there were osteoporotic fractures here, presumably secondary to a combination of smoking and age and maybe drinking. We checked the light chains as well, and the ratio is normal, which is a really important point. So even though those numbers look high, a normal ratio is very reassuring. But again, I think because there was uncertainty about whether there could be an underlying myeloma, a bone marrow was done. It should be made that in many situations, you won't need to do a bone marrow biopsy in MGUS, because it will be clear that the patient has a normal blood count, normal renal function, doesn't even have any symptoms of bone disease. And in those situations, we wouldn't even consider doing any imaging. So the diagnosis here is IgG kappa MGUS, and the patient was monitored in primary care. Now, in terms of how MGUS is monitored, it's done differently in different parts of the country, and a lot of it does, I think, depend on funding pathways. I think the key thing is that ideally patients should be really well educated on what MGUS is, why they need monitoring, and they should really take ownership of actually ensuring that they are monitored to ensure that bloods are done at regular intervals. Now, in certain groups of patients, you only need to do the bloods once a year. Other patients may need monitoring a bit more often. What I generally recommend, if the patient is being monitored in primary care, is if the light chains or the paraprotein goes up by more than 25% on 2 consecutive occasions, or there are any concerns about developing symptoms potentially of myeloma, whether it be bone pain or an emergent anemia, then the patient should be referred back. I'll just give you an example of someone we diagnosed with what we thought was MGUS, and certainly behaved typically as MGUS in September 2016, a relatively small paraprotein with low light chains, but then there was a very rapid increase in the light chains from when they were checked in March 2017 to a year later. And actually what happened in this situation is that the patient was supposed to have at least one blood test in between, but it was missed for whatever reason, and the patient presented with active myeloma. But as you can see, one of the things about when we treat myeloma is because the cancer produces an abnormal protein, you can see those proteins going down, and the patient responded well to treatment. So I've been through this in terms of most of this in terms of follow-up. I think there are groups of patients with MGUS who do not need to be followed up. Those who are going to die of something else sooner. Probably patients over 80 don't need to be followed up as well. And there is a group of patients that actually have a very low risk of progression. Those with a normal light chain ratio probably have a 1 to 2% chance of progression over 20 years. We're getting better data about how to follow up these patients. There's some very interesting sort of AI-based and machine learning work going on, because in this group of patients, there are some patients that are absolutely going to progress, probably within a shorter time frame, and there are patients that will never ever progress. And we don't have the capacity to, and as you don't either, to endlessly monitor patients who are actually never going to progress, and you're measuring something that they don't need to know about and perhaps only adds stress. But it's how do you avoid actually monitoring those patients at all, and just make sure you monitor the patients that need following up. And I think within 5 to 10 years, we're going to be much better at doing that. Briefly, polyclonal hypergammaglobulinemia. This is something that we do get a lot of questions about, I think understandably, and again, I think is a little bit misunderstood. So anything that causes inflammation and infection can raise all your immunoglobulins. So you check your IgG, your IgA, and IgM, and everything has gone up, but there's actually no paraprotein. And usually in this sort of situation, you will see raised kappa and raised lambda, but again, the actual light chain ratio will be normal. And I think that's a really important point. And normally it's a finding that's in keeping essentially with inflammation and infection being the most common causes. It's quite common also in certain types of autoimmune diseases like Sjogren's and lupus. So we're always more than happy to advise on polyclonal hypergammaglobulinemia, but normally there is an underlying cause that, and it's generally best that those patients are guided towards the more relevant population. So just a little bit about myeloma, just a summary as a final slide about myeloma. We're all seeing much more because patients are living so much longer. 20 years ago, basically everyone was dead within 2 years, but now there is increasing survivorship. But we're at the stage at myeloma where we're much better at keeping people alive, but unfortunately we're adding layers and layers of morbidity from side effects of drugs. They're having to live with chronic spinal problems, especially if they presented with bad bony pain for longer. And these patients take, understandably, a lot of time and a lot of effort, and we sometimes don't give them the best quality of life that we could, and hopefully we will get better at giving cleaner drugs and intervening before they get significant morbidities that really affect their journey through myeloma. Unfortunately, there's a small group of patients that still, whatever we do, seem to die within 2 years. And treating myeloma on the NHS can be quite frustrating because they're a very fixed way in which we can give drugs in certain ways, and this doesn't suit everybody, and also means that you sometimes end up treating people in ways that don't suit their side effect profile and their age and their comorbidities because of what is available. And that's where in the private sector, thankfully, we don't have that kind of problem. And the newest agents, unfortunately, are not routinely funded by NHS commissioning at the moment. And CAR-T therapy isn't either, but should be something that we're able to offer later in the year at HCA at UCLH. In terms of where we work closely with you in primary care, for our myeloma patients, is I think the management of chronic symptoms, chronic pain. We work very closely with you all, and palliative care, management of neuropathy. A lot of the drugs we use cause neuropathy, and also in the palliative care phase. Now, I am mindful that the time is 7:45, so I did have a few slides on lymphoma, but I think I'm just going to focus on a couple of things just to finish off with. Ali did talk a little bit about lymphadenopathy. You guys are the experts, actually, when it comes to reactive lymphadenopathy, and you see so much of it. And as you know, infection tends to be, and definitely is, the most common cause. But there are malignancies, including lymphoma and metastases, that, of course, can cause lymphadenopathy. And the classic teaching is, of course, that tender lymphadenopathy is likely reactive and goes away over time by itself, of course, which it tends to do. And malignancy that is perhaps tethered is more typical, and painless is more typical of a malignancy. Phenytoin is the classic drug that causes lymphadenopathy, and of course it is very common in autoimmune disorders as well. As a general rule, if you think it's reactive, it probably is, and I'm sure what you will do is say, come back in a month, and it's usually gone away. But if it has been present for a number of weeks, then refer in via the pathways that Ali talked about. The approach to diagnosis is taking a good history and examination and doing the simple investigations there on the that are noted there. And the key thing about lymphoma is that we need good bits of tissue to get the diagnosis. We can't diagnose lymphoma on an FNA. Ideally, we like an excision biopsy, but our radiology colleagues are so good at taking core biopsies now that in lots of settings, good cores are adequate for diagnosis and show the lymphoma in its lymph node architecture, which is really important for diagnosis. Usually symptoms are due to a lump, whether it's in the brain, in the mediastinum, or in the neck. And there's so much more that we can do than we used to be able to do for a variety of types of low and high grade lymphoma. And I'm just going to do literally one more slide again, just around how we work with you in terms of lymphoma and how you get involved. Is that sometimes when it comes to the long-term complications and the long-term management of patients who've had lymphoma, you're often involved. And a few points to make on that. Our lymphoma patients are immunosuppressed, and we would recommend that they have pneumococcal vaccine with boosters, annual flu jab for life, and of course COVID vaccines as well. Patients who've been exposed to certain types of drugs can have cardiac issues, normally due to anthracyclines, and it's important to get those factors monitored regularly and annually. There is a risk of second cancer depending on the type of treatment that is given. And patients that have had thyroid irradiation, for example, need annual thyroid function, scrotal irradiation need annual testosterone. Chemotherapy can cause premature menopause. So I think if you see patients in your clinic that come to you that have been maybe discharged from lymphoma clinic or haven't been seen for a while, and have a non-specific symptoms, it's good to potentially think, could they be immunosuppressed? Could there be cardiac issues? Are there hormonal issues? And they've had this sort of treatment, so I need to keep an eye out for a second cancer risk. So I think I'm going to call it there, and I hope that's been interesting and useful.
Thank you so much. Conscious of time, we have had a few questions come in, so I think we can jump straight into the Q&A. So if I can ask all the consultants to come back in. So the first question, I believe you may have covered this already, but if low B12 caused by metformin can't really stop the drug usually.
Yeah, yeah, absolutely. So I completely appreciate that. And vitamin B12, oral vitamin B12 can sometimes overcome that. So extra vitamin B12, but yeah, I completely understand that. And sometimes if there's no options, just extra vitamin B12 should overcome that malabsorption caused by the metformin.
Thank you. Not so much a question, it's a comment. Low vitamin B12 in my practice is most common in vegetarians, more than the causes you listed.
Absolutely right. Absolutely. Diet obviously is extremely important, and obviously, especially in certain group like vegetarian, and in these cases, most cases, just oral vitamin B12 is all that is needed. Absolutely right.
Thank you. What level of raised HB would be considered significant? Would persistent borderline 17.4 hematocrit 0.511 be significant?
I think hematocrits above 0.5, usually in men, they would say is considered as raised. So in most cases, if it's persistent, it may need further investigations. If it's been stable for many years and you've got previous results, then it would be reasonable to leave it. But if it's above 0.5, I think generally in those cases it's worthwhile sending for JAK2 for JAK2 mutation.
Thank you. And what is a high B12 level to be concerned?
Oh, okay. Well, I mean, I think above 1,500. Some people. So if you look at what they say, there are a lot of B12 levels. Again, it depends on the labs as well. I think in our lab, above 778 is considered as raised. But between if it's above 1,500, I still would say that if the blood count is normal, liver function is normal, there's no worries of liver disease, there's no hepatosplenomegaly, that I don't think it needs further investigations actually.
Thank you. Which common antibiotics can cause neutropenia, pancytopenia commonly in teenagers? Neutrofurantoin, PenV?
Yes, so both of, I mean, basically most of the antibiotics, so semi-synthetic penicillins like amoxicillin, ampicillin, vancomycin, chloramphenicol, sulfonamides, cephalosporins, erythromycin, but probably the most common I would say are chloramphenicol, which is mainly the reason we don't use it. We only really use it for topical preparation. Trimethoprim sulfamethoxazole is the sort of classic, and nitrofurantoin and erythromycin.
Thank you. Does neutrophil left shift comment of a blood film report always indicate bacterial infection?
No, is the short answer. In the context of having a raised white cell count with left shift and a fever, one would assume that there was probably bacterial infection. But left shift comment on its own just means that you can see cells that are not just mature cells. It means there are mature cells there, but there are also less mature cells there as well. And that is an abnormal finding on a blood film, and it could be from many causes, including bacterial infections, including any sort of stress on the bone marrow, or from a hematological malignancy. So it's not, I mean, I guess it sort of speaks a bit to what I was saying about the comment. The comments can be really helpful, or they can be kind of descriptive, and perhaps less helpful.
Thank you. What about low or borderline platelets in a normal?
Okay, but we didn't really, none of us really talked about thrombocytopenia. Thrombocytopenia I taught for another day, but what I would say is that you know, a lot of the comments about low borderline platelet count probably are reflected, it's similar to a low borderline neutrophil count, so on its own probably less of a concern. Think about associated clinical conditions and drugs, so rheumatological conditions, immune conditions, and medications. And certainly if it's just very borderline, repeating is absolutely fine, because the level at which your platelet count needs to be low enough to be concerned about bleeding, it is very low relative to the normal range.
Thank you. We've got a couple more questions. So back pain and myeloma, how important is ESR?
Good question. So ESR goes up when you have a paraprotein as a general rule. but it's also a non-specific finding. So I think the key thing is that back pain is so common. Myeloma isn't, but I think when you do the bloods in a patient with back pain, just check serum electrophoresis and serum-free light chains. And then if you have a patient who has a combination of back pain and a paraprotein, then refer up, because then we have to decide whether we think it's myeloma or we think it's MGUS. We are seeing so many patients now with MGUS and osteoporosis, but we do need to use advanced imaging and a bunch of other associated tests, and sometimes we even need to do a bone marrow, sort of as in the kind of case I described, because it can be very difficult to tease out sometimes. But yeah, as a screening test, absolutely send an ESR, but please send serum electrophoresis as well.
Thank you. So we've had a comment to say many thanks for a very stimulating presentation. My question is, do we need to worry about a persistently high ferritin above in an asymptomatic adult?
I'll come to that. A raised ferritin with normal transferrin saturation, I think if they've got normal transferrin saturation, you've got raised ferritin, the only thing I would always do is I'll do an ultrasound to look at for liver to make sure they don't have any kind of, they very likely may have fatty liver. If there's no underlying inflammatory process like rheumatoid arthritis, things like that can cause a raised ferritin. But high ferritin, as long as the transferrin saturation is normal, doesn't necessarily need any further investigations. Because I know that there's raised ferritin, there's a lot of talk about can it be a sign of cancer? But I think on its own, when it's been persistent, then I wouldn't necessarily do any further investigations.
Amazing. Thank you so much. And perfectly on time. You guys have been incredible sticking to the time frame. We haven't got any more questions from our audience, so I think this might be a good place to end the webinar. But before we all sign off, I would just like to take a moment to say a very big thank you to our consultants for presenting this evening. A big thank you to our audience for joining and for your engaging questions as well. Thank you to our events team for arranging this brilliant haematology webinar. Following the webinar, you will all receive an email link to share your feedback, so please take the time to complete this, as we truly value your comments to improve for future sessions. CPD certificates will be emailed to all attendees as soon as possible, but if you have any more questions for us or would like to know about referral pathways or any of our consultants, please do reach out, and yeah, we'll be glad to help you. So thank you all again. I hope you have a wonderful evening. Thank you.
Thank you. Bye, everyone.
Thank you.
Bye.